Everyone, this is Adam again, and we're going to continue on the next lecture in Bio. Here we're going to talk about surveillance of epidemiologic concerns and outbreak investigation. Here are some of the objectives that we're going to cover today, so read those at your leisure. So typically, as far as surveillance of epidemiologic issues goes, it's really this process of collecting, we're analyzing, trying to interpret all this kind of reported data that comes in. And it's going to include several different things we're talking about, including like death, diseases, injuries, or even like prevalence of like certain conditions. And we've talked about a lot of those reportable diseases previously. Within the U.S., it's mainly handled by the Center for Disease Control and Prevention in Atlanta. And, this can be something where there is some active monitoring for a lot of these things, for some of these conditions that we're looking at. But you can also find that services may be requested if there's like a particular outbreak of a disease in the state. They can request the help of the CDC to come in and investigate. Or, if they feel like there is an outbreak with a potential to affect more than one state, then they may be able to intervene on that to try to help control the spread potentially. And so, they really work pretty much hand in hand with state and local agencies, and they kind of figure out, what kind of further investigation is really needed and how can they get a control on the problem that's been discovered. And kind of like what we mentioned on the last slide, according to the Constitution, the federal government kind of has jurisdiction over matters that, really concern, state to state commerce, and that can include things like disease outbreaks that have interstate complications. So, if there's an outbreak confined to one state, usually state governments can kind of handle that. But if it starts to spill over potentially, that's where the federal government will come into play, and the CDC is typically the first responder. They'll have physicians and other healthcare providers that can respond to a site to start to do their investigations to kind of figure out what's going on, what the scope of the problem is, and how can they initiate treatments in order to hopefully help prevent spread. And so they utilize different surveillance systems, and one of the big things that you need to do when first starting up a surveillance system is have a pretty clear objective about what you want to cover. So for instance, we have things like infectious diseases. We have surveillance programs for side effects of vaccines. So anytime you have a vaccine being given, you report any type of side effects that occur from that. Lead levels, pneumonia, poisoning is a really big one for me personally, because my involvement at the Poison Center, all of that data actually gets reported not only nationally but also to the Florida Department of Health. And we have a very robust kind of active monitoring for different poisonings, and you can look for things like outbreaks of specific like street drugs. They're becoming more prevalent. You can do things like looking for carbon monoxide poisonings related to generator use during a hurricane, different things like that. And so it's really important to have these surveillance systems in place so you can monitor for changes, trends, etc. And so, like I mentioned, the objective needs to be pretty clear. So, for example, if we're looking at surveillance of chickenpox, trying to determine if the varicella vaccine is actually effective or not, that'd be one thing you could potentially look at. Or if you're looking for side effects for new vaccines. So, for instance, when we had to kind of rush out when the swine flu hit several years ago, we had to kind of rush out a new version of the flu vaccine. And so one of the things was one of the big concerns was that they didn't think enough safety data had been reported prior to being released. And so that's why you kind of monitor these things as time goes on. And the next thing to determine if someone actually has whatever disease or condition you're looking at is to make sure your definitions are appropriate. So these case definitions usually end up being based on like either clinical findings or laboratory results, or if they're looking at things that may not be quite as clear cut, but things like time, place, characteristics of affected persons, things like that. Now those are all things that can kind of guide you to saying, okay, yes, this person is considered a case, and then what do you do with that information afterwards is then kind of the next portion of the surveillance system. Now we have different forms of surveillance. We have active versus passive surveillance, and we'll talk about those in just a few minutes. But you also have to know kind of what your duration of surveillance is going to be. And so, that can, especially things like, flu incidents. If you're looking for flu, like obviously you're not going to look during the summertime because that's not when flu is really all that active. Look more during like the winter months. Then after that, you have to consider what kind of analyses you're going to be doing. So looking at analyses of incidence, prevalence, if you're going to be looking at things like case fatality ratios, cost, all these different things need to really be stated in advance. So you have a plan when you get this information, you get new cases that are being caught. What are you going to do with that info? Obviously, you're going to have investigators. They're going to be part of the surveillance program that help to collect, report, and utilize the data. And typically, what they'll do is they'll do like a pilot test run prior to actually being fully implemented. So that way they can look for any kind of inadequacies. They can look for anything they might need to change or modify about the surveillance. And then when it's eventually being put out there in the world and actually used, it has to be subjected to continual evaluations. Are case definitions being applied appropriately across the different investigators? Is the data being looked at and evaluated correctly? Those kind of things are going to be done as the surveillance goes on. And a lot of this information can be found from the CDC if you ever get involved with something like this. Now, generally, most of the surveillance that we do is going to be done on a passive basis, and this means that the surveillance systems are relying on cases actually being reported. So, for instance, if you're utilizing either physicians, laboratories, hospitals, they are required to report a disease. We saw that list previously of things like meningococcal disease or things like HIV. And honestly, there is really no way to actively enforce that. And this is why I call it passive surveillance. You're relying on these people who have been instructed to report these sort of things up to the surveillance system. And again, we see that there's some inherent problems with that, especially with underreporting of these different types of diseases. Active surveillance, on the other hand, is going to be a lot more labor intensive and costly to perform. It's not really done super commonly, but maybe if there's some kind of high profile new infectious disease or something like that, it may warrant it. But basically, it requires someone actually going out to either their different institutions or having some other means of communication on an active basis to try to get these reports. As I mentioned, most of these are going to be done passively, most of the surveillance, and you can find that the reporting can vary pretty considerably even from state to state. Some people estimate anywhere between 30 to 62% of these cases of reportable diseases actually end up getting reported. So again, underreporting is typically one of the big issues we run into. And sometimes even these surveillances can start to show problems you might not have actually known were there in the first place. So even changes in medical care can help out with this. So for instance, there's a case where there's a hospital in Connecticut and they were reporting kind of this abnormal number of cases of this pharyngeal gonorrhea in young kids. And so this actually, it looked like an apparent localized outbreak, and so because of that, it ended up leading to this response team from a public health institution to actually go out there and look at it. And so what they were finding is that the cases actually began to appear after the hospital were examining all these throat cultures in kids for gonococcal disease, plus and when they were looking for beta hemolytic strep. So throat cultures are a pretty common thing you're going to do. If you started to look for gonorrhea in cases where you weren't looking for it before, well, you're just going to find more cases, probably just as kind of a coincidence. So it's one of those things where the numbers or the rates of disease actually probably wasn't changing all that great. It's just now you're capturing these cases when they they would have been uncaptured before. And so generally these surveillance systems tend to develop kind of on a problem by problem basis. So, when we have cases of like Zika was one of the big ones that we were dealing with in the past few years, to where we were really concerned about mosquito spread of Zika virus and affecting Florida. And so this became a really big thing that was had a high focus, had a kind of a high profile. And so we were doing much better reporting of this, mainly because when you saw something, you're like, okay, this seems pretty severe. You're going to kind of have it higher under differential when you're trying to rule things in and out for your patients. And so again, that can help to change the way we're going to be surveilling for these sort of things. And so what you find though is with a lot of these systems, without appropriate support and funding from governments, they tend to be pretty difficult to develop and to support kind of in the long run. And so what you find is that most of these systems kind of start off as kind of basic, demonstration projects. We're kind of looking at a few areas, and then as it starts to demonstrate utility, then it kind of gets expanded from there. And you may see either statewide or nationwide kind of utilization of these surveillance programs. So when you're surveilling for different patterns of disease and things like that, one of the big things you want to know is your baseline. And generally, epidemiologists are going to use data about rates and patterns of disease based on kind of regular reporting that's being done previously or with the surveillance systems. Generally, you can study patterns of disease by looking at, say, the time frame that it becomes more prevalent or less prevalent, geographic location of certain cases, and then also the characteristics of the kind of people that were involved. What type of risk factors were kind of predisposing these people to disease, or maybe have been protecting them in some cases. And so by looking at this continued surveillance, that will help epidemiologists to look for like deviations, looking for whether an epidemic, in this case, an unusual incidence of disease is occurring, whether it could just be, just random chance, or it could actually be something going on. Maybe, there's been an alteration in the reporting practices, or maybe there's lots of different factors that go into it. And these are sort of the things, the deviations and patterns are what kind of trigger the epidemiologists to kind of look at it with a kind of better magnifying glass. So when looking at kind of long stretches of data, it's important to consider that kind of long-term changes or trends of disease typically are going to be of greater significance in the long run than kind of short-term outbreaks or epidemics. For an example, we're going to be looking at a graph here from the CDC. It's looking at cases of salmonella, and they show a pretty significant rise in the number of reported cases seen over time. And so you have to start to question, is it an issue of changes in disease detection? Are we picking up cases that we were previously not picking up? Has the reporting changed for some reason, or could it be both? Or is the actual disease itself changing? Basically, when you see a real or suspected outbreak ends up being announced, you may actually find that your index for suspicion for people practicing in the community actually goes up. So for instance, if you think about things like Zika virus, it's kind of on the forefront of your brain, you see it in the news every day, you may be more likely to suspect it in your patients than you would have if you had never heard about it before. So again, these are things that can help to change trends in reporting or potentially in detection of some of these diseases. So here's this graph kind of showing trend over time of time here on the x-axis and the number of reported cases per 100,000 population. Again, you remember why we look at cases in terms of times 100,000 population or 10,000, what have you. But anyway, over time you can see here that there's a general increase in reporting, and then you end up seeing this outbreak. So again, it's kind of a short-term case, because then as the outbreak due to contaminated milk was kind of contained and dealt with, then it kind of goes back down to where it was at baseline, and then we start to see kind of dip off a little bit. And so they were concluding that most of the observed increase from say 1955 to 85 tend to be true and tend to be actual real, mainly because they were seeing increasing numbers of outbreaks that were occurring, and then also just the fact that over the extended time period you were seeing this continual trend increasing. So it wasn't necessarily you had a new means of diagnosing salmonella. It was just that the numbers kept going up. There's more outbreaks happening. That seemed like there's actually true increase in the number of people being getting salmonella. And so we saw this was especially true for places like New England and the East Coast, where we saw big outbreaks or at least an increased number of outbreaks caused by salmonella beginning around 1977. And so, these long-term increases in disease, especially in kind of one region in the U.S., generally is going to suggest a greater kind of public health concern or significance than just a localized outbreak. Sometimes, an outbreak could just be kind of a one-off kind of thing or just a coincidence, whereas these kind of increased trends over long periods of time, especially they're kind of geographically located, could kind of clue you in that there's a more of a widespread issue. So in the next figure here, we're going to be looking at the decline of reported incidence and mortality from diphtheria in the U.S. And you're just going to notice here on the next slide that the y-axis is going to be on a logarithmic scale, and then the x-axis will be on a more of an arithmetic scale. So the benefit of using a logarithmic scale is that you can actually show that things like the incidence of disease and mortality you're going to see are going to be approximately parallel in decline, and so that's useful because we can see that essentially the percentage of cases, people that actually get the disease that result in death, or this case fatality ratio, tends to remain pretty constant at about 10%. So obviously if you see a decline in the incidence, the number of people, kind of just the baseline number of people dying is going to go down as well, although the proportion stays about the same. And so we'll see that just in a second. This is basically suggesting that this is more to do with the prevention of disease. Our treatment's not necessarily getting any better, because ideally we would see that case fatality ratio would start to diminish over time, but it's really just saying that we're preventing more people from getting the disease in the first place. So you can see on this graph here, here would be the actual incidence of disease. Here's the introduction of things like the antitoxin, the toxoid being administered, and then here we have kind of more of a general use of the product. You can see a pretty sharp decline here in the incidence of diphtheria. Here again, there's mortality. Again, it's going down pretty parallel for the most part. So again, the same proportion of people who get the disease are still dying. We're just seeing fewer people actually getting the disease, and thus the number of people actually dying from it are going down as well. You can notice here in the case fatality ratio that is being pretty consistent in the number of people dying essentially. One of the other important factors to include on this kind of surveillance is to look at seasonal variation. We know that several infectious diseases tend to have a strong association with the seasons, where especially things like ones that are spread by the respiratory route. So if you think about things like influenza, measles, varicella, they tend to have a higher incidence here in the winter times, which we're just heading into now, and the early springtime months in the northern hemisphere. So we just know, like, we know when flu season is going to come, and that's when we can do things like introduce the vaccine. And we only know these variations based on a lot of the surveillance that we do. We can look for differences in trends over time. We can look for all these sorts of things based on the surveillance that we have. And so we'll see in this next figure is going to be showing seasonal variation for varicella in the U.S. And so you're going to notice the peaks generally happen after January and then before summer of each year. And so the pattern occurs due to the thought that people are spending most of their time close together in indoor environments. So if it's cold outside and you're hanging out next to the warm fire, you're in close contact with people and you're more likely to spread disease potentially. Not only that, but you also see that during the wintertime months it tends to be drier, so drying of the mucous membranes tends to play a role in kind of promoting the spread of these respiratory infections. And we'll see that since the introduction of the vaccine, the seasonal pattern has largely been eliminated, since a lot of people were experiencing a lot of herd immunity and kind of preventing spread of it in the first place. And so really this graph is just showing just how reproducible and how pretty predictable many of these cases can be with some of these infectious diseases. So again, usually things like varicella will hit their nadir kind of here in the summertime, and then start to pick back up towards the winter months, and then kind of peak around the January, February kind of time frame, then can go back down. So really the only things that will change stuff like this is generally if there's kind of individualized outbreaks, potentially an epidemic, or maybe if you had something that could actually prevent the disease from occurring in the first place. For instance, if you had like a vaccine, they could basically just knock the numbers down to very, very small amounts. So you can see things like diphtheria, they tend to strike, especially in the early kind of autumn time period, and that's generally going to be commensurate with the return to children to school. And we'll find that diseases that spread via insects or arthropods, so think about things like viral encephalitis from mosquitoes, they tend to have a predilection for the summertime and early autumn. Again, when there's more mosquitoes out there, people are out on vacation, they're kind of out being active. Think about things like Lyme disease, usually acquired during late spring or summertime. This tends to be related back to the life cycle of the ticks, and just being around the same time as a high amount of outdoor activity. And during summertime, you're generally wearing less protective clothing than you would be in the winter, and so again, you're just more exposed to potential ticks and things like that. So again, there's generally a reason for a lot of these kind of trends that you see, but sometimes you have to look back at not only the vector itself that's spreading the disease, but also things like the host factors that may make someone more susceptible to it. We will see that infectious diseases that are spread by the fecal-oral route tend to be most common in the summertime, and this kind of corresponds with the ability for these organisms to multiply more rapidly in things like food and water during the warm weather. The warm climate, warm temperature tends to increase the reproduction of a lot of these organisms. So again, that tends to peak up during the summertime months. And we'll see a graph here in just a second that's showing kind of the summer seasonal pattern of these waterborne outbreaks of gastrointestinal disease. You notice kind of the peak frequency of outbreaks, especially from like drinking water sources, kind of occurring in the May to August kind of time frame right there during the summer, with the peak frequency occurring from these kind of recreational water sources. So you think about things like warm lakes, rivers, swimming pools, and that can occur between say like June to October. And you also have to consider things like the spread of flies. Them being more active during the summertime may contribute to the spread of disease as well. So again, here you can see the number of cases that are being reported via each month. Again, looking at water intended for drinking, again peaking around the summertime versus the recreational water. And again, depending on what the sources you're looking at, it may shift these peak incidences around slightly from one range to another. But again, generally June, July timeframe tend to be the most active timeframe for a lot of these gastrointestinal diseases to have occurred. So in that previous graph, we saw that the peak incidence tended to is occurring right in the middle of the graph, and we call that an epidemiologic year, where essentially we kind of skew where the beginning and the end of the year is in order to show the peak incidence kind of happening right in the middle, and so that it kind of helps to avoid cutting off high incidence peaks between two ends of a graph. That becomes more important when you're looking at the varicella charts. You don't want to cut off right at the January, because again in January that's when you're starting to really kind of ramp up and you're starting to see those peaks happen there. And so that's why you might see what we call an epidemiologic year, and graphs may not start in January and end in December. It could be starts in July and ends in June. There's other types of variation you can see. Certain health problems may vary by the day of the week. So for instance, recreational drownings can be more frequent on weekends or on holidays potentially. And so again, this is mainly because that's what they're doing. If they're not at school, they're not at work, they're hanging out at the pool or at the lake. This is when stuff like that is just more likely to happen. So again, if looking at a number of drownings by day of the week, obviously Saturday and Sunday tend to be much more common that you would run into with just a weekday type of drowning. So we've talked about the words epidemic and disease outbreak. Obviously, that's just really, in the strictest definition, an occurrence of disease kind of at an unexpected or unusual frequency based on kind of baseline data. Typically, the word epidemic tends to create a bit of fear in a population, and so because of that, we try to, if we're just talking about kind of a localized sort of epidemic, kind of a one geographic location, we tend to use the word outbreak. Probably since the movie Outbreak came out, that also carries a lot of kind of negative connotations with it, but it's easier for a lot of people to swallow that term than epidemic. They think all of a sudden we're running rampant with zombies or something like that. But basically, it's only possible to determine if we're having an unusual outbreak of disease or an unusual rate or an epidemic if we know what the usual rates are in the first place. And that's why we need really reliable surveillance to kind of know what the current rates are, to kind of know what the current trends are, to see that is what we're experiencing right now just a blip? Is it just a something we would have expected normally, or is it actually a true outbreak or an epidemic, something that is out of the ordinary? So one example of us, kind of being able to identify and document these outbreaks includes influenza and pneumonia outbreaks. And so basically the CDC uses essentially a seasonally adjusted expected percentage of deaths associated with influenza and pneumonia, and they will have a certain threshold that they have. We call this the epidemic threshold, where if we start to see deaths due to influenza and pneumonia above a certain number during a certain time of year, then this is considered to be kind of the epidemic threshold, essentially. So again, obviously that number is much lower in the summertime, and you wouldn't expect a lot of deaths due to flu and then pneumonia, versus that number might be much higher during the wintertime. And again, it's seasonally adjusted to account for those normal changes in variation of reporting. And so pneumonias are included in this because a lot of times if someone had an influenza-induced pneumonia, that would not be captured by the death certificate. So by including that definition of pneumonia, that will increase your numbers and kind of probably make it a little bit more closely to what is actually occurring out there. Because again, we know that generally we're having under-reporting of a lot of these diseases. So the next graph we're going to look at is pneumonia and influenza deaths caused in many cities over a 6-year period. The lower line we're going to look at is going to be kind of the expected frequencies based on historical data, where the upper dashed line is going to be the epidemic thresholds. Anything kind of above that would be considered an epidemic, would be considered abnormal based on the normal kind of variation in that kind of baseline pattern. And again, typically flu, pneumonia tends to have kind of the most sophisticated prediction models, basically because it's kind of what has the most research behind it and kind of the most kind of experience. So you can see the black line is going to be the actual proportion of deaths. We're going to see the dashed line is going to be the epidemic threshold, and this the blue line is going to be the seasonal baseline based on just what we know. And so you can see here, there's a lot of cases where you're going to have some variation, obviously, in the data, but there's going to be these blips here. You can see, okay, well, this seems pretty high above the epidemic threshold. That would probably be considered an epidemic. versus here again, let's see another epidemic occur. And again, this could be related to certain areas, depending on kind of where you're looking at data from. Lots of different factors go into it. But again, once you're above that dashed line, that would be your epidemic threshold. You can say, yes, this seems to be an epidemic happening. And again, that just refers to something happening at an unexpected rate compared to what you would see based on historical data. Surveillance for bioterrorism is also another really important aspect of the CDC, and looking for possible bioterrorist attacks that could be occurring here on U.S. soil. And so the big thing to consider here is kind of this rapid detection of a problem. A lot of these cases of things like anthrax, of botulism, they may not be super apparent if you weren't really thinking about them in the first place. It just could seem like someone's coming down with some other disease than what actually could be occurring. And so they develop kind of special surveillance techniques that covers kind of the most common or most likely agents of bioterrorism to try to help us to identify them more easily. And this detection can be pretty difficult, if it's spread out over a wide geographic area. So if you think about the anthrax outbreak that occurred after 2001 terrorist attacks, all those different politicians opening up their boxes with this white powder in it. What do you look for after that? Like, how do you determine whether this is anthrax or possibly something else? We call this syndromic surveillance, which is basically looking for certain signs and symptoms that are very consistent with some of the agents of concern. And this allows us to, without having an actual definitive diagnosis, because some of these kind of definitive testing may be very expensive or time consuming, but this allows us to kind of catch on to these things a little bit more quickly, and allows us to kind of maybe sound an alarm, maybe start the investigations a little bit sooner if one of these attacks was actually being considered based on the syndromic surveillance. Some of the kind of major threats that we consider are things like anthrax, botulism, smallpox. These are things that normally, if you were evaluating a patient in the emergency department coming in, say, for upper respiratory tract symptoms, like, you wouldn't be thinking any of these diseases off the top of your head. This wouldn't be on the front of your differential. But if you were to have certain this syndromic surveillance, you're starting to notice, hey, there's a lot of people being reported for symptoms that are consistent with anthrax. That kind of alerts people to say, hey, maybe we should look at this with a kind of a better magnifying glass and see if there's something actually going on here. And so this can be very useful. Again, without having a definitive diagnosis, just having those this kind of outbreak of these signs and symptoms consistent with the disease can be kind of get the ball rolling a little bit sooner. You can also use surveillance to look at the effects of interventions designed to change patterns of disease. So especially when you're looking at things like vaccines, you want to make sure that it's, you introduce a new vaccine, it's actually taking care of the problem that you're trying to solve here. And so in the next figure, we're going to be looking at two types of polio vaccine, the inactivated and then the oral vaccine. And then against the reported cases of, or incident cases of poliomyelitis. And so you're going to see this is actually on a logarithmic scale on the y-axis, and that's mainly due to the fact that the decline was so steep in the incidence of polio that you weren't really able to get a good scale of things when you're on the arithmetic scale. So this is why we did that. And then also using a logarithmic scale helps to compress the kind of the high rates on the graph compared to low rates, so that the detail can be seen a little bit better. But here you can see when we have the inactivated vaccine being introduced, you're starting to see a pretty decent decrease in cases, incident cases of polio. And then when you had the oral vaccine being introduced, we saw an even sharper decrease. And so again, you want to do this kind of surveillance to make sure that the actual disease is being reported in fewer cases, and you can know that your drug's being effective, essentially. So it's very important that we do that kind of surveillance. And so looking to see things like the failure of a vaccine to kind of produce satisfactory immunity, or maybe even the failure of people to use the vaccine, can be detected by several things. So looking at the graphs, if you were to see a lack of change in disease rates, that would probably indicate either people aren't using it or the drug is actually pretty ineffective. That's how we can tell if we have, say, bad years versus good years of the flu vaccine. We know that every year the flu vaccine gets formulated against different strains of the flu, and thus sometimes our prediction models are really good and we can have relatively low incidences of flu being reported, or sometimes we're going to have bad years and we have bad predictions and people still end up getting the flu, or relatively higher rates of people getting the flu. You could also look for things like an increase in disease rates after an initial decrease. That may be indicative of people kind of getting complacent and thinking, hey, we've gotten rid of this disease, don't have to worry about immunizing anymore, and then all of a sudden start to pick back up once you kind of lose herd immunity. And then it also could be looking at for things like increases in disease rates in a recently vaccinated group. This can occur if you have like a bad lot of the inactivated vaccines. As an example, in the 50s, there was just one made by Cutter Laboratories. It's kind of a bad batch, and people were not truly protected against polio. So that could be another sign of something just not being right. So here's a really good example of why surveillance is so important and how that can actually have pretty big impacts on how we actually administer a lot of these vaccines. We're looking at measles rates in the U.S. and by looking at surveillance, we were detecting that the single vaccination really was not providing kind of long-lasting protection for a lot of these patients, and people are still getting the disease, a decade or two after they had been initially vaccinated. And research into that problem, once they were seeing the trends, they were leading to new recommendations, in which case you would be dosing kind of initially at around the 12 to 15 month old range. We saw that you couldn't give it too early because then that would lead to a greater failure rate based on kind of the immunity status of these children. The second dose was to be given around years 4 to 6 before they're actually entering school, and again being in kind of close contact with lots of new pathogens. And then third dose before college entry was also recommended. Again, that could only be done by research led by this kind of surveillance. Another really good example of surveillance could be after medications have been released onto the market. And I mentioned anytime you take a drug, you're kind of part of a phase 4 clinical trial, essentially, where you monitor for side effects being reported for these drugs, especially new ones out on the market. In this case, there was a drug where we had specific COX-2 inhibitors. They're doing this for kind of gastroprotective purposes, but there were drugs that only affected COX-2, and rofecoxib was the big one, or Vioxx is the brand name, ended up being removed from the market due to increased risk of cardiovascular death. So we realized that just is something that you wouldn't see just testing thousands of patients. It took millions of patients taking it before we really found this incidence was just too high for our own taste. It was just too dangerous of a drug, and so we got that off the market due to surveillance. I'm sure you guys have seen plenty of advertisements like this where, hey, have you taken Vioxx, or have you taken Zofran, or have you had a metal hip replacement, or there's lots of different things where they're looking to get cash settlements for people. But a lot of cases like this came up mainly due to the fact that this drug was released on the market. We couldn't, there's no way to have gotten a good sense for those sort of kind of 1 in a million type side effects with the current clinical trials that we do, and so it just ended up being a bad drug, so we had to pull it off the market, and unfortunately some people got harmed by that. So looking at the trends for disease tend to kind of help set priorities for especially governmental agencies and voluntary agencies to devote time, money, people power, things like that. It's things that are more severe, or things that are kind of increasing in rates very rapidly. Think for instance like AIDS, back when that was being recognized as a big a problem as it was. They tend to get a lot more concerned, especially things like media portrayal and things like that. The bigger the kind of public perception of the problem it is, the more likely it is to get a lot of research money and all that thrown at it, versus if the rates are pretty steady or they're declining. Again, severity of disease, I mentioned, is a very critical feature, and this can usually be established if you have good surveillance to kind of track these sort of thing. And so that's why AIDS receives such a high priority, mainly due to the fact that it's having this kind of epidemic spread, and it became a very severe sort of disease that led to death in very many cases, especially when it's kind of first being discovered and kind of characterized. So again, good surveillance helps us to look for these different patterns of occurrence of a particular disease over time. And so a good example of this was looking at surveillance of syphilis cases in New York City during the 80s. And they were noticing these changing patterns of acquired and congenital syphilis. And so one of the things they were able to kind of attribute it back to was this basically the epidemic of crack cocaine. Once crack became much more prominent, especially during 1987, they started to see all these women starting to develop these primary and secondary syphilis cases. They also were seeing an increase in the congenital syphilis that was being, babies were acquiring, that was being strongly associated with women's use of cocaine. Primarily, if they did not have money, they were trading sex for drugs, and the fact they had pretty poor prenatal care. People that are doing, or a lot of these patients who are doing a lot of cocaine, typically were not taking good care of themselves, especially if they were pregnant. And this is where you saw a lot of these congenital syphilis cases coming up. And so again, sometimes the pattern of occurrence may kind of give you a clue into something much more ominous than just the increase of syphilis. It could be something as ominous as like this kind of problem of crack cocaine. It can be much more kind of ominous issue. So looking at these cases of primary and secondary syphilis in females, you see on this black line here how it went up pretty sharply in response to the introduction of crack cocaine, and then similarly congenital syphilis incident cases also went up pretty significantly around the same time. So just remember when investigating epidemics that the definition is unusual occurrence of a disease. And so some people think epidemic has to include tons of people, but even just one case of a disease could be considered an epidemic. Imagine if smallpox, a single case was discovered. That could represent an epidemic. That's a disease we otherwise thought is eradicated. Polio in the Western Hemisphere, say measles in the U.S. These are all things that we have relatively gotten rid of. So even one case would be considered epidemic for our definitions here. Now another definition would be endemic, and this would be if something, a disease in a population was occurring pretty regularly at a more or less constant level. This basically just comes from the Greek meaning within the population, right? So keep the difference between endemic versus an epidemic. You could even apply this over to animals as well. So if you were to see say an unusual outbreak of a disease in an animal population, you call this epizootic versus enzootic, which would be something that may be deeply entrenched in kind of this animal population, but it's not really changing very much. Another term that investigators may use when looking at acute disease outbreaks is what we consider this attack rate. This is basically kind of a quick measure of disease frequency, and it's going to be useful when you're looking at periods of exposure. It's pretty short, so if you'd say if you're looking at a period of a month or a week or something like that, so usually less than a year. And so this isn't really like a true rate that you could determine say over a year time frame or something like that, but the attack rate is going to be that proportion of people who became ill that may have been exposed to a particular factor. So in this case, the attack rate equals the number of new cases of a disease, so people that actually became ill, divided by the number of people that were exposed in a particular outbreak times 100. So for instance, if you're looking at, say, an outbreak of food poisoning, you traced it back to a particular restaurant, you'd be looking at the number of people who became ill after eating at that restaurant versus the total number of people that may have ate at that restaurant during the time frame, so say over a few days or so. And so that would again give you the attack rate. Again, it's not trying to look at the number of people that became ill at that restaurant over a full year. You're just really looking at a very specific time frame. So in general, we find that during normal occurrence of disease, kind of the forces of both prevention and causing disease tend to be in equilibrium. If an epidemic is occurring, then obviously that equilibrium has been disrupted some way. And so the goal of the investigation is to try to kind of look at and discover and try to find out what changes occurred so that kind of the balance can be restored and kind of get back down to kind of the normal occurrence of disease. And so the provider who is typically alert to possible epidemics not only would be concerned about giving the correct treatment to individual patients, but also would be asking, well, how come this patient became sick with the disease right now? This is kind of an odd occurrence. It's not usual. What the heck was going on to do this in the first place? So again, not only treatment, but also kind of seeing something else going on here that I'm not aware of. And so the first step is to establish your diagnosis. Again, sometimes you're doing that kind of syndromic surveillance where you're looking for signs and symptoms consistent with a particular disease. But once you have your diagnosis established, and even though this may seem kind of obvious, it may be surprising how many people start off by investigating an outbreak without kind of taking the step first. You find that many cases end up being solved just by making the correct diagnosis and showing that the disease occurrence actually wasn't that unusual in the first place. So for instance, there's a health department in North Carolina where they're receiving these kind of panic calls from several people who were concerned about having smallpox in their community. And so they had a physician who was working in the health department and was assigned to investigate the matter, and was actually discovering that the smallpox that people were complaining about was actually just chickenpox. Turned out the child's mother, this child with quote-unquote smallpox didn't speak English very well and just heard the word pox, and they panicked, and they found out that the outbreak was not really an outbreak because they just didn't have the right diagnosis. Next off, you want to establish what your case definition is, and so usually you're going to have a list of very specific criteria that will be used to determine whether or not a person actually has the disease that is of concern. This is not the same as a clinical diagnosis. Basically this is just establishing kind of consistent criteria that will enable the investigators to kind of proceed. So even if you don't have a specific diagnosis made yet, you can at least have an idea of what people kind of fit the criteria, people that may warrant further investigation. So for instance, an example of the disease was unknown was in the CDC had a case definition for eosinophilia myalgia syndrome, and it included basically total eosinophil count greater than 1,000 per microliter. You had generalized myalgia at some point during the course of illness of sufficient severity to try to limit the ability to pursue normal activities, and exclusion of other neoplastic or infectious conditions. So you kind of rule out a lot of stuff right there, and you also want to have signs and symptoms consistent with the syndrome that you're looking at. Obviously, no case definition is going to be perfect because there's always going to be some false positives. We've talked about sensitivity and specificity before. In this case, false positives would be individuals without the disease that actually got included in the group considered to have disease, and then there also is going to be some false negatives, so people who were not included as a case even though they actually had the disease in the first place. So again, it just allows us to kind of start to include people, start to kind of come up with an idea of what were the kind of common characteristics here that kind of link these people together, and it allows for epidemiologists to also start to make comparisons among findings from, say, different outbreak investigations. So if they saw something very similar 6 months ago at a different, say, county or a different state, they can start to look to compare and contrast and try to figure out, hey, what are the differences here? What are the similarities? Is there something we can kind of glean from this other information to look for differences and trends? Obviously, these epidemics need to be characterized by time, person, place, and all these criteria used in the definition, and you really don't want to start data collection until you have a good idea of what your definition is going to be, mainly because if you were to start to collect all this data, you may find out, oh, actually we need to have collected this lab test, and now we have all these people that you don't have this lab test for, and now it's impossible to determine whether they're really cases or not. So you can come up with a good case definition, figure out what you're going to need to, what kind of questions you need to ask, what kind of tests you need to perform, and then start your data collection. That's really going to be the most kind of epidemiologically sound way to do things. So as far as time goes, the time dimension of the outbreak is going to be described by what we call an epidemic time curve. And so basically you're going to see the times on the x-axis and the number of new cases on the y-axis. And so these curves should be created so that the units of time on the x-axis are going to be considerably smaller than the probable incubation time period for the disease. And then the y-axis is just going to be the number of cases that became symptomatic during each time interval. And so you're going to find that rates generally are not going to be used in creating these curves. And we'll look at a few examples of these so you can kind of get a feel for what they look like. Now, these curves help us to provide several important clues about kind of what is happening in an outbreak, and helps us answer some of the following questions. So first off, what was the type of exposure? Was it a single source, or perhaps was it spread from, say, person to person? What is the probable cause of spread or route of spread? Is this going to be a respiratory issue? Is it a fecal oral? All these different, is it animal or insect spread? Those are all good questions to ask. When were the affected persons exposed? And then what was the incubation period? So the time frame between someone who got ill, when were they exposed to when they actually developed disease? And then in addition to some of the primary cases, so people who were initially infected, say, from a common source, were their secondary cases. This may be due to person-to-person transmission of disease or something like that. So again, you're looking for both primary and secondary cases when you develop curves like this. So So in a common source exposure, you're going to find that many people come into contact with the same source. So this could be something like contaminated water or food store over a short period of time. So typically you're going to find that the curves have a pretty sudden onset peak and then a rapid decline for those initial people who are all exposed, generally around the same time. If it's due to person-to-person spread, then you'll find that the curve has much more of a prolonged kind of irregular pattern, and this is referred to as a propagated outbreak. In the next figure, we're going to show you epidemic time curve from an outbreak of GI disease that was caused by exposure to Shigella at Fort Bliss in Texas. Basically, we had the spaghetti that was contaminated by a food handler, and then you're going to notice that the time scale here has been shifted down to 12-hour periods. And so you're going to note the rapid increase after common exposure and then the rapid disappearance of the outbreak. All right, so you're going to note here that the y-axis again is just going to be kind of the new incident cases that are occurring, whereas the time frame here on the x-axis is going to be in 12-hour increments. And so you're going to notice that based on, obviously the 12-hour increments can be shorter than the incubation time. You need to figure out basically when the exposure was to the the possible source, and then you're going to notice around the same time, most everyone is going to get the disease kind of become symptomatic around the same time frame, right? Because this is all based on when they were similarly exposed to the common source. And then you see kind of burnout very quickly, right? Because again, people are not spreading it from one another. They all got exposed to that one food source. Most of the people probably were contaminated or they became symptomatic around this time, were contaminated around the same time. Maybe these people got leftovers the next day or something like that. But again, it happens very intensely, very quickly, and then burns itself out. The next epidemic curve we're going to look at is going to be propagated outbreak, and this is going to be of dysentery caused by Shigella that was transmitted from person to person. And basically, this was a training school for mentally handicapped individuals in Vermont. And so, basically, the spread of disease was again propagated, and this is through contamination of clothing, bedding, people in the school environment with feces. And you're going to notice here the time scale is going to be much more drawn out into 5-day periods. You're going to notice here it's going to be a lot more kind of dragged out kind of appearance of the outbreak due to spread from person to person and from person to other fomites and fomites back to the people. So you notice here the graph gets broken up into both staff members and then also the residents. Notice the time frame is going to be in 5-day periods. And then you'll notice that the different color of the boxes will indicate different definitions. So again, just the white box would be people who develop febrile diarrhea. The gray boxes would be the cultures that end up being positive for Shigella, and then these dots in the boxes include people who are kind of managed in the infirmary. So essentially what you find is you have this index case being reported here. You have the index case actually end up returning to the facility, and then this is when you start to notice people are becoming more symptomatic or developing these cultures here. And again, notice this is going to be kind of much more dragged out. You notice that the residents start to have some spread over into the staff members around this time period. Again, this is being propagated from person to person, so rather than just having one common source of exposure and then it burning itself out. Now, in some cases, you can have person-to-person spread of a disease appear almost like a common source sort of exposure. And so we'll show you a curve of this in just a second of measles that had an outbreak in an elementary school. And basically, this could all be tracked back to a school assembly to where everyone was kind of in the same room together. The air was kind of a common source of exposure in just that area. And so you can see what the curve will look like here. So some things you'll notice on this graph and on the next slide here is that the initial case can be considered the index case. And so this is basically when the organism was introduced into the population. And you'll notice there were some individual cases that occurred after the index case was documented every 12 days or so, during the prior 2 months. And so if people had been more cognizant of it, or if they had at least taken it as more of kind of a warning sign, they may have been able to immunize the kids in that school much more readily and maybe have prevented an outbreak from occurring. But unfortunately, this is not what had actually happened. So if you're looking at this again with the time frame being, you can see how it would be broken up in every 2 days. on the x-axis here, you'll notice there was the index case that occurred, and there's a few other kind of random cases that pop up here and there after this kind of initial exposure to an index case. And all of a sudden there's a school assembly where you can kind of consider that to be a kind of a common source exposure. You notice a really big uptick in people developing measles, and then all of a sudden they had a vaccination clinic, and this was able to greatly diminish the number of people that were having kind of new incident cases of measles occurring. So again, it looks like very similar to a common source exposure. Notice that if you had not had a vaccination clinic, you might have seen it look much more like a kind of propagated sort of outbreak, like we saw with that previous case of Shigella. So you'll find that sometimes you can have epidemics that will have more than one peak, and so this can happen with multiple common source exposures or possibly due to secondary cases, so from cases developed from the primary cases. And so you'll look at the following figure. It's going to show a time curve for an outbreak of shigellosis among students who attended a camp in the eastern U.S. Basically, they drank contaminated water on the trip. They got infected with Shigella, and then after they returned home, they ended up infecting others with Shigella, and so those ended up becoming the secondary cases. So you'll notice here, the white boxes are going to be the campers on the trip. This light gray is going to be camper not on the trip, and then the bus driver was in this dark gray box here. So you can kind of notice they were exposed to the water at some point at camp. Notice here that a lot of the campers on the trip end up becoming symptomatic, returned home, and then all of a sudden you have people who were not on the trip actually getting infected as well. So these are kind of these secondary cases that are starting to pop up. So kind of a bimodal sort of peak here. So there could be situations in which two different common source outbreaks that had the same time and place of exposure, but maybe had different incubation periods. So for instance, if you were to look at a group of people exposed to, say, contaminated shellfish in a restaurant, the exposure might cause a case of, say, shigellosis in, say, 24 to 72 hours after exposure. And then there could be an outbreak of hepatitis A about 2 to 4 weeks later. So again, different exposures, same common source, but again, the incubation times are very different. So you kind of, maybe some people got just one or the other, maybe some people got a double whammy in these cases. But again, you can look at these different curves and kind of see how they can compare to one another. Now, epidemic time curves can be very useful to ascertain the type of exposure and to try to determine when affected people were exposed, right? Especially if you have an idea of what the causative organism is, and we already have some idea of what the incubation period is going to be. And if we can determine kind of what a common source is, and that's all determined based on history and interviewing people, and along with that usual incubation period, that really helps us to determine what the probable time of exposure was. And again, the more history you can get, the more good information you can characterize this outbreak, the better you are to contain it basically and control it. Now, we can establish these time curves by basically one of two methods. Method one is going to try to take the shortest and the longest known incubation period for a causative organism and try to calculate backwards in time from the first and the last cases. Essentially what we're going to do is, if the estimates are going to be reasonably close together, then they can basically bracket the probable time of exposure. For example, for the incubation period of Shigella, usually it's going to be about 1 to 3 days, 24 to 72 hours, but it can range from anywhere from between 12 to 96 hours. So using that Shigella example with the campers shows that the first two cases occurred after noon on August 17th. So if the case is looking at the shortest incubation period, the exposure was then sometime before noon on August 17th. Okay. The longest known incubation period for Shigella is 96 hours, and then the last camper case was on August 21st afternoon. So if you were to take that 96 hours and backtrack it from the afternoon of August 21st, you would see that it would be August 17th afternoon. This means that the most probable exposure time was either before noon or afternoon on August 17th. So you're kind of looking to see, based on the earliest exposures and what the shortest incubation period is, and then the last exposures with the longest incubation period, try to see where they kind of line up. And again, this is going to give us an idea of kind of where the exposure actually occurred. Now, if the same procedure had been used but applied to the most common incubation periods, so say 24 to 72 hours, the result you end up getting is going to be an estimate of afternoon on August 16th from the earliest cases, and then afternoon on August 18th from the last case. So you can see here it's a wider range you're getting from that. And so the two estimates still pretty much center on August 17th, so it's pretty reasonable to assume that the campers got exposed sometime during that day. So again, using the shortest incubation periods for the first cases reported to the longest incubation period for the last cases reported, tracking that to probably sometime on August the 17th. Method 2 is pretty closely related to method 1, but it's going to involve taking the average incubation period and trying to measure backwards from the epidemic peak, if that is pretty clear. So we saw in the campers case that this one was pretty clear peak, and so for this we saw that the peak was around afternoon on August 18th. We had about an average of 48 hours, or 2 days earlier would have been afternoon on August 16th, which again was slightly earlier than what the previous estimates were going to be. And so by looking at these different models, we can say that the most probable time of exposure was probably either afternoon on August 16th or any time during the day on August 17th. So if it's probable that the exposure occurred whenever a camper happened to be drinking water on August 16th to 17th. So then you can try to backtrack that to, okay, what were they doing on that day? Where might they have been exposed to contaminated drinking water? And you can try to narrow it down to a specific focus. You know, maybe it was a contaminated water pump or something like that. So again, using the average incubation period, you can see here, this would probably be our peak. Backtrack that, say 48 hours is our average incubation. We would see it would be sometime here on the 16th. Now, next up is looking at location. You would like to have accurate characterization of an epidemic as far as the geographic location of cases is concerned, and based on the geography, it can reveal some important clues. And so just knowing where it happened may not be sufficient on its own. You kind of have to have other data needed to complete that interpretation. So what we can use sometimes is a spot map. This is going to show us where each affected person lives, works, and goes to school, and that can be more helpful in kind of narrowing down. Not just saying like, hey, it happened in Orlando. You can maybe narrow it down to like, maybe it was Disney, or maybe it was downtown, or maybe it was somewhere more specific than that. I've talked about this before, but kind of the most famous spot maps was prepared back again in 1855 in London by John Snow. Apparently he did know something, knew something about cholera outbreaks, because he was able to look at these outbreaks, see where they were living at, and kind of was able to link it back to a particular water pump that had been infected on this broad street in London. And so by having the pump handle removed, and basically by inactivating the pump, people had to go get their water from elsewhere, and then this led to a lot fewer people being infected with cholera in that particular area. So again, looking at different streets here in London, you kind of notice that, hey, this broad streets where just looking at the number of dots all around this particular area, you can kind of see that, yeah, this is probably somewhere being kind of the location, the center of the epidemic is probably somewhere around this area. And so again, we removed the pump, even though the kind of the numbers starting to dwindle anyway, they definitely saw a decreased incidence of new cases of the cholera. So use of spot maps can be limited in an outbreak investigation. Many of these maps maybe only show the numerator, right, or the number of cases, and don't really provide information about the denominator, right, or the maybe number of people who were potentially exposed, right, not just the people who actually became symptomatic. But epidemiologists generally prefer to show incidence rates by location. So you can look to see, like, say, by hospital ward in a hospital infection outbreak. You can look by work area or classroom if you had to say more occupational sort of setting, or by block or section of a city, if in the case of like a community outbreak. So a good example where trying to characterize the place of an outbreak that is really important. This is an example of a fungal respiratory infection in an Arkansas school, showing how the rates by classroom could actually give you a clue as the cause of the outbreak. And so this is a case where all but one of the classrooms had, say, 3 or fewer cases each. The exception, though, was being this room named the Liberace room. I'm not sure what it did to acquire that name, but I'm sure it was something very special. And it had 14 cases, which tend to be pretty abnormal. So they noticed that the room was actually located over a coal chute, and the coal had actually been dumped on the ground and shoveled into the chute during several windy days. And so based on this, based on the location of that room, became very dusty from the coal, which had come from a strip mine and had been contaminated with Histoplasma capsulatum from the soil before it was actually delivered to the school. So because of that, the kids were inhaling this dust. Locationally speaking, they were the only ones that were exposed to it, or at least to the greatest concentrations, and they ended up coming down with histoplasmosis. So when epidemiologists wish to determine kind of a general location, what they can do is actually compare trends of incidence rates in different regions. And so basically the next figure is going to show reported salmonella infections by region in the US, basically from 76 through 89. And so according to the figure, you're going to see there's kind of an unusually higher rate for New England region from 78 to 89. And then beginning in about 1984, see these mid-Atlantic states also began to show kind of excessive salmonellosis of the same serotype, kind of suggesting that the problem was spreading down the East Coast. So here you can kind of see there's several lines that are being reported out here, but basically the New England is going to be the solid line here. You kind of see had the highest incident cases, and then all of a sudden you start to see this mid-Atlantic start to kind of creep up here right around the mid-80s or so. Okay, so the question is, okay, is it starting to spread? What's going on here? By looking at these different trends in cases, the epidemiologists can start to see is something else going on. It kind of helps to spur further questions and further investigations. So one of the big difficulties that epidemiologists will have is when you have kind of disease clusters, in a lot of cases, disease clusters can happen just by chance alone. And so it's really difficult to determine, is this just random chance or is there actually real clusters of things that are actually occurring? So for instance, if you're looking at reports of cancer or other type of diseases, say like in specific neighborhoods or other small areas, right? Again, it can be very difficult, but there's means we can use to try to delineate between just coincidence and actual something else going on. So specifically when you're looking at cancer, like looking at the type of cancer can be really important to try to distinguish if it's an environmental problem or not. So for instance, if you have kind of multiple types of cancer being reported, so different varieties, say like lung cancer and prostate cancer, that's not really indicative of a kind of an environmental problem, right? Or if it's particularly more of a common sort of cell type of cancer, so I mentioned like breast cancer, colon cancer, things like that. That tends to not really be a strong case for kind of a hazardous local exposure. However, if all the cases are being reported of, say, just one type of cancer, or if it's related to a very specific or kind of more rare type of cancer, so especially if you're looking at things like leukemias, thyroid cancer, brain cancer, they may be more indicative of something going on in the environment and maybe require more of a closer investigation. So the investigation generally is going to begin at the time the cluster is reported, and they're going to observe kind of the situation prospectively. So again, they're kind of looking at time moving forward in this case, and they have to use, go back into our biostats using the null hypothesis that the unusual number of cases would not continue. Again, it was just due to coincidence, just due to chance alone. And so because we are using kind of a prospective hypothesis, we're going to use an appropriate statistical test. We're going to decide whether or not these cases, the number of cases that continue, do they tend to be excessive? If the answer is yes, then there could be an actual true environmental problem going on, or at least some sort of common exposure leading to this cluster of cases. So again, null hypothesis, there's no difference there. We would not expect to see this continued cluster of cases being reported, but that it does continue on. If you start to see that the tests are statistically significant, then that may indicate that yes, there's something going on in the environment. So by knowing the characteristics of the people involved in the outbreak, that can also help to clarify the case. So looking at things like age, sex, ethnicity, religion, immunization status, all these different factors come into it, which is why interviewing patients and interviewing people in the area tend to be so important to get a better, more clear idea of what the kind of common risk factors are, what the common sources of exposure happen to be. For instance, if it's all the people that work in the same place, or if it's people that say practice the same religious practices or something like that. You can all link it back to something of a common source, hopefully. So the next figure is going to show you why it's important to look at the characteristics of individuals that are being affected, to look at the cause for an outbreak. And so the first figure shows the age distribution of measles cases among kids in the Navajo Nation, and then the next one is going to show the same thing, but looking at residents among Cuyahoga County in Ohio. So this first one here, looking at the age distribution for the Navajo Nation, you can see here that generally is going to be pretty young when the measles cases are happening. So again, less than one, and they typically are going to kind of trail off as they get older and older patients. Versus if you're looking in Cuyahoga County, you notice they're very rare that people would be getting it very early on in life, yet the peak is going to happen here later on, say in kind of early adolescence. So the question is, what are the common differences here? Why are you seeing this different in age, presentation for these different So looking at the individual characteristics for these different populations, you can see it goes back to different practices. So for instance, the early distribution of measles for the Navajo Nation tended to be related back to the fact that they were not immunizing young preschool children. So that's why you saw a lot of people end up getting it very early on. And then due to a little bit more of a durable immunity against measles, they did not see it later on in adolescence. Compare that to children who are being immunized in Cuyahoga County. A lot of them were being immunized very early on, but what we see with the measles is that if you do not have repeated exposure or repeated booster vaccinations, you tend to see that the response is not super durable, and that people in young early adolescence tend to get it again, which is why we see, as I mentioned earlier, we have that kind of three different times you get the measles vaccine in order to help make sure you have a strong, durable response. So if they were not immunized early, the kids in Cuyahoga County probably would have had measles exposures very similar to what they would have seen in the Navajo Nation, or they would have gotten it by the time they had entered school, essentially. And so this type of outbreak, as we've seen, has been mostly eliminated by having kids get a second dose of measles vaccine before they enter school. And that helps to kind of boost their immune response and prevent them from coming down with the disease while they're in school. So when we're trying to develop these hypotheses regarding a source for an epidemic, the type or the route of spread, it's important to make sure definitions are together. And so again, the source of infection may be a person, which we call the index case, or it could be a vehicle, including things like food or water, that actually brought the infection into the affected community in the first place. That's kind of the source. The pattern of spread is going to be considered that pattern by which infection can spread from the source to the individuals affected, whether it's by consuming the food, whether it was fecal oral spread, things like that. And then when looking at the way that it's spread, if you have a common source pattern, we mentioned is going to be when you have, say, contaminated water being drank by many people during the same time period. Again, they're all getting it from the same common source, versus what we're going to see with a more of a propagated sort of pattern. That being when you're going to have the infection propagate itself by spreading directly from person to person, again being over more of a kind of a long extended period. And then we mentioned that we can have a mixed pattern, which is going to be where people acquire the disease from a common source and then possibly spread it to other family members or other close contacts, making these secondary cases, usually due to personal contact. Now, for some common source outbreaks, you may find that people may have just a very short point, kind of single exposure, or they could have more of a continuous kind of common source exposure. So, for example, in the Fort Bliss example, we were talking about the contaminated spaghetti. And they weren't having spaghetti every single day and night, I don't imagine, but there's one case where one night they had spaghetti, and boom, that was your exposure. However, in an example of Milwaukee back in '93, they had an epidemic of cryptosporidium infection that was caused by contamination of public water supply over a several day period. So that in that case was more kind of a drawn out period. It's more difficult to kind of identify those kind of sources when it's a kind of a longer period of time they're having these kind of chronic exposures to. It's still common source exposure, it just may have been over a longer period of time. And then we see that many types of infections may have more than one pattern of spread. So we mentioned Shigella can be spread through contaminated water, which is a common source, or it could be due to person-to-person contact, which would be more of kind of a propagation sort of pattern. HIV can be spread to several intravenous drug abusers just through sharing, say, one infected needle in a syringe. That would be, again, a continuous common source. Or it can be passed from person to person due to sexual contact. That would be an example of propagated spread. The mode of transmission can be pretty widely pretty varied. So you can have respiratory spread, fecal oral, vector-borne, so different things, which you guys are all pretty familiar with. We're going to find that laboratory studies are also going to be really important for helping us to determine several things. So we can look at things like cultures from patients or from possible vehicles. So we can look at food, water. You can look at stool examinations, serum tests for antibodies to, say a suspected organism. This may help us to look for things like, acute or convalescent samples to determine if maybe there was, say, an increase in antibodies to an organism over time that can be useful in some cases. Or we can look for, say, non-microbiologic agents. We can look for things like toxins or drugs. Think about lead exposure, things like that can be very useful. So one kind of common efficient way to test our hypothesis is basically to do a case control study. Again, this is more of kind of a retrospective sort of case or retrospective sort of study. And so what we can do is we can see, for example, if there, say, has been a foodborne outbreak of disease, what we can do is we can actually assemble cases, people who actually developed disease, and then a sample of controls, people who did not develop disease. And so what we can then do is kind of go back and look for possible risk factors. So in this case, if you think it's foodborne outbreak, it could be look at common sources of food that were eaten, right? Or maybe foods that were eaten by the cases that were not eaten by the controls, right? So again, if it's considerably more common that all the cases were eating spaghetti versus all the controls were not, then that may lead you to think, hey, maybe it's just spaghetti, right? Both groups end up being questioned regarding specific foods they did or did not eat before the outbreak. And then for each item, food and drink, you basically look at that percentage of controls who consumed it, subtract it from the percentage of cases who consumed it, and so kind of give you an idea of what was more likely to have occurred in those cases versus the controls. The food items showing kind of that greatest difference in consumption percentage is going to be the most likely risk factors. May not be a slam dunk, but it tends to be the most likely thing that has caused this, and at least can help you narrow things down and give you a better kind of avenue for investigation. You can do a case control method also on, say, an epidemic of, say, non-infectious disease. So, for instance, in case we had these 8 young women with adenocarcinoma of the vagina who were treated in one hospital between 1966 and 69. This is a pretty rare type of cancer, and so because of these, even though it's a small number, it would be considered an outbreak because against an abnormal incidence of these cancers. Basically what they did was a case control study done using 32 controls, so basically 4 matched controls for every case they had. And what they saw was that the only significant difference between the cases and the controls was that 7 of the 8 cancer patients had been exposed to something called diethylstilbestrol, or DES, in utero. Basically, it was a synthetic estrogen that had been given to the mothers during the first trimester of pregnancy in an effort to try to prevent miscarriage or to prevent premature labor. Right? We don't really do this any longer, and a lot of it goes back to this case here. What they found was that none of the 32 controls were the offspring of mothers who were given diethylstilbestrol during pregnancy. So essentially, the probability of them finding these differences between the cases and the controls was infinitesimal. So very, very unlikely due to chance alone. So they're able to kind of link it back to this common exposure, this their mothers being exposed to diethylstilbestrol in utero. So looking at control measures, so when you have an outbreak that occurs, generally there's going to be an outcry that something should be done immediately, and it may be necessary to start taking control measures before you really have the source of the outbreak, or before you know what the route of the spread are known. And so if possible, these control measures should be initiated in a way so that it does not interfere with the investigation of the outbreak itself. That's kind of the other important thing there, is you don't want that to have any interferences, and you kind of getting a better definition of what's going on and how it's working. So 4 common types of intervention that may be used to help control an outbreak. One is sanitation. This usually involves, say, like modification of the environment. So it could be doing things like removing a pathogenic agent from the sources of infection. So maybe getting rid of water or contaminated food, Could be removing the human source from infection, so maybe quarantining certain people away from the general population, or by preventing contact with a source. So for instance, if you were to move, say, susceptible people from an environment, so we do this a lot with like lead cases, where trying to determine common source for lead exposure, and if you can get the people out of the environment where they're exposed to lead, then hopefully will lead to less exposure, right? You can do prophylaxis, so this may be putting a barrier to the infection within susceptible hosts. So this can include things, like a variety of immunizations that get recommended for population. A lot of these are again begun during infancy. We can see short-term protection may be done in some cases for people who say plan to travel to other countries. So for instance, anti-malarial drugs or immune globulin for hepatitis A, things like that. With diagnosis and treatment of the people who are infected, so that way we can actually, the infected people do not spread it to others, so if we can get them treated early, that helps prevent spread. And then also looking at control of disease vectors, so things like, if it's a mosquito-borne disease, like getting rid of the mosquitoes, etc. So although an outbreak may require one or more interventions, you're going to find that sometimes an outbreak will simply fade away if enough people have been infected. Typically this means you will have a smaller pool of susceptible individuals, and that could be one that kind of burns itself out. And then another important aspect of the control effort is going to be kind of written and oral communication to try to make sure that this information makes it to the appropriate authorities, health professionals, the public. It's important that communication is key here, and it's important to couch these kind of communications in order to not scare the public, but certainly to make sure that they are taking all the appropriate actions. So this will also enable other agencies to assist in disease control, helps contribute to a professional kind of fund of knowledge about the causes and control of outbreaks, and maybe that can be translated into other places who may not have been affected yet. And again, just helps to add to available information regarding prevention. Now, there's also this idea of follow-up surveillance, and so of course no medical or public health intervention is really adequate without kind of following up to determine to see if what you did was effective or if the problem is still persistent or not. And so usually a sound surveillance program is going to be able to detect subsequent outbreaks and try to evaluate the effect of your control measures. And then by having the surveillance after an outbreak should really be or should be focused on active surveillance, right? To make sure that you're trying to limit that underreporting that normally occurs once people kind of have not thought about the disease for a while. They may not really be on the forefront of their minds anymore. So let's look at a sample investigation of an outbreak. Let's say back in 1991, there was a liberal arts college in New England with a population of about 400 students, and it reported 82 cases of acute gastrointestinal illness, mostly among students over about a 102-hour period. The president of the college, we're trying to get some help from, say, local and state health authorities, and we're trying to figure out whether the college cafeteria should be closed or whether the entire college should be closed and the students at home, right? Because they were worried about these, it seemed like nearly a quarter of their student population was coming down with this gastrointestinal illness. So they decided to start an investigation focused on making a diagnosis. So basically what they had was some clinical data suggesting that the illness was pretty short in duration. They found that most of the students got better in 24 hours. It was pretty mild. Only one student ended up being hospitalized, and that they consisted of nausea and vomiting with, say, little to no diarrhea and only mild symptomatic symptoms. They had maybe low-grade fever, headache, and malaise. And so utilizing this stuff, you can kind of get an idea for what your case definition is going to be. Okay. They also knew that initial food and stool cultures end up coming negative for any kind of pathogenic bacteria. Okay, so now you got an idea of, okay, well, people that don't have these positive cultures, people who have these signs and symptoms consistent with this, may fit into your definition of what a case will be when doing your investigation. So that definition ended up being defined as any person in the college who complained of diarrhea or vomiting between Monday, January 28th and Thursday, January 31st. Okay, they found that a large percentage of the cases over the time period made it clear that the situation was unusual and pretty higher proportion than they would expect. So they went ahead and considered that a disease outbreak. People meeting the criteria for the definition included both resident students. They also found that commuter students and employees are being affected here. So again, that is important Because if it was only, say, included students, or I'm sorry, resident students, maybe it's something with the dorms. If it was only commuter students, that might indicate something else. So the fact that it was affecting kind of all people at the university will give you some clues as to what the actual source was. And so when the investigators were interviewing samples of these groups, they found that most, but not all, of the resident students had eaten only at the campus cafeteria. So again, another clue to the investigation. They made an epidemic time curve that was suggesting that if cafeteria food were the source, that basically one or more meals on 2 days in January could have been responsible. Although a few cases may have occurred, say, before or after the peak, they're able to kind of narrow it down to this 2 days being the most likely. Again, not 100% sure, but they're thinking this is most likely it. Near the beginning of the outbreak, they had 2 food handlers who had worked while feeling ill with gastrointestinal symptoms, right? So they started doing more interviews and found out these 2 guys were not feeling well. And then the health department records revealed that the school cafeteria always had high scores for sanitation. So they knew that in general the cafeteria was pretty good, but maybe it was something else to do with maybe these 2 guys. So they conducted an emergency reinspection of facilities and found no change. The sanitation for the cafeteria was still really pretty good. And so they found no problem in any kind of sanitary procedures except for the food handlers who happened to be working while not feeling well. That's kind of the only abnormality that was going on there. Here is the epidemic time curve that they generated here. So you'll find that the white blocks is the employees. The light gray is commuter students, and then the dark gray is resident students. And it makes sense that the resident students would be most affected by this, mainly due to the fact that they live on campus and they're more likely to be eating there in the cafeterias. And so again, based on where the peak had occurred, they can kind of assume, hey, it's probably one of these 2 days where people are being exposed to whatever the infectious source is. So the investigators went back and they were asking commuter students and found that most of them had brought food from home during the time of questions. So it kind of limited kind of those type of exposures. It was unlikely they were, the food brought to school by the commuter students was affecting the resident students. And then almost none of them had eaten at the college cafeteria, although a few had eaten at the snack bar in the student center. So that's, again, could be another confounding factor there. And so further questioning revealed that the family members of several of the affected commuter students also had similar illnesses during the week preceding the outbreak, or at least concurrent with it. So this may be like, okay, well, maybe these are secondary cases that are now being spread, say, from the commuter students back to their family members. So within 2 days of being summoned, the investigation team basically was able to make the following recommendations. They said that the college, including the cafeteria, should probably remain open. They went ahead and had college-wide assemblies, indoor sports events should be canceled for 2 weeks. And that way it would prevent kind of spread in those kind of close quarters sort of environments. And then that no person should be allowed to work as a food handler while ill. So of course that should probably go without saying, but again, they were kind of going back and making sure they reinforced that. To show their confidence in the cafeteria, the members of the team actually ate lunch there and sat in a very prominent place. And then afterwards, the outbreak quickly faded away, and the college schedule was able to proceed more or less normally. So again, even though it was considered an outbreak, it was not something of, Walking Dead-like proportions. Again, the term epidemic usually has a pretty negative connotation, but it could be as simple as, a case of people coming down with illness at a cafeteria. So again, the following observations made the diagnosis of bacterial infection pretty unlikely. So for instance, they were looking at the fact that it was self-limited, pretty mild course of disease, and the lack of reported diarrhea, even though it was in the original case of definition, they found that a lot of people were not developing this. They could not find any bacterial pathogens, so that's again another strike against it being bacterial disease. And then they were looking at potentially staphylococcal toxin being considered initially, but the story really wasn't consistent with what they were finding. So again, they can rule things out, rule things in based on kind of the disease course, and it gives them a better idea of kind of what specifically they're dealing with. So their clinical and epidemiologic patterns seem to be pretty consistent with outbreak of norovirus. So again, no good definitive laboratory test can help us with that, besides the ones that were able to rule out things like parasites and whatnot. And so laboratory demonstration of this can be pretty difficult and costly, and so again, because it's such a mild disease, it probably was not warranted in this case. But we do know that for noroviruses, that fecal oral route of spread has been shown for both food and water, and we see that many outbreaks show a pattern pretty close to this, kind of suggesting even a respiratory or like a propagated route of spread. So the latter was the reason for suggesting cancellation of the assemblies and indoor sports events, so that way people are not potentially spreading it to one another during those kind of close quarter kind of events, I should say. So it was unlikely that the cafeteria was the only source of infection because, again, a lot of those commuter students who were bringing food in, were still getting ill as well. But looking at the short duration, the mild nature of disease meant there was no need to close the entire college. But they did some continued surveillance afterwards and found that the outbreak was certainly dying out, and the cultures continue to show negative results there. So even without having a truly definitive diagnosis, they can say, hey, it was probably norovirus. It definitely wasn't any of these more serious things. And that way, by doing the follow-up surveillance, make sure nothing else was kind of going on, or say there's like a resurgence of illness or anything like that. So, in summary, surveillance of disease activity is the foundation for public health control of disease. Remember, it can be active or passive. And basically, our functions here are going to be determining baseline rates of disease. We're looking for outbreaks, trying to evaluate these kind of control measures that we're implementing. And as data is used for setting disease control policy in a lot of cases, so the things that are kind of the new rapidly increasing or the very severe diseases, those usually get set as high priorities, and a lot of it's based on the surveillance that we do from both state and governmental or federal organizations. All right, so that concludes this section. If you have any questions, please let me know. Otherwise, I'll see you for the next one. Thanks. Bye.